those of you just joining us, welcome to the 17th Annual Cosumnes River College and Sacramento State Center for Practical and Professional Ethics Fall Ethics Symposium, The Ethics of Providing Healthcare. I'm Rick Schubert, Executive Director of the event series of which this symposium is a part. Our final session for today is entitled Defining Affordable Healthcare. Our presenter is Dr. Govind Persad. Dr. Persad is assistant professor at the University of Denver's Sturm College of Law. His research interests center on the legal and ethical dimensions of health insurance, healthcare financing, and markets in healthcare services, as well as professional ethics and the regulation of medical research. He holds a BA in philosophy, a BS in biological sciences, and a PhD in philosophy from Stanford University, as well as a JD from Stanford Law School. As with our previous sessions, this one will be an hour and 20 minutes in length, divided roughly equally between our presenter's presentation and an open question and answer session with you, the audience. As a segue between Professor Persad's presentations and the open Q&A, we'll hear from two formal respondents briefly, Hannah McKeno, a CRC Honors Program student, and Professor Melissa Alexander of the University of Wyoming College of Law. Please join me in welcoming Professor Persad to the podium.
Thanks, everyone. And I feel like also compared to my other speakers who were earlier on Friday, I feel more grateful to anyone giving up their 3 to 4 hour on a Friday afternoon, which is otherwise an hour for napping, for instance, to be here. So I'll forgive people if I see them sort of, there's a lot of space stretching out over the back seats. So what I want to focus on for today, and I'm really grateful to be going last because I do get to draw on what some of our speakers have talked about before, is a topic that gets talked about a lot in policy and politics, but often doesn't get defined, which is the question of what does it mean for health insurance, health care, pharmaceuticals to be affordable. So in our first presentation, we talked about, for instance, what are insurance affordability standards that different states have adopted. And I want us to think about this question more broadly about what does it mean for a health care service or for health insurance to be affordable. So one thing that we know is that policymakers, legislators, and the public in the United States seem to care quite a bit about affordability and regard affordability generally as a good thing. So obviously the Affordable Care Act, affordable is right there at the start of how people often talk about it. It's the Patient Protection and Affordable Care Act, but the short acronym in policy is usually the Affordable Care Act, or ACA. And then there have been other efforts as well that also tend to center this concept of affordability. So in 2021, legislation was proposed federally called the Protecting Access to Affordable Medicines Act that again focused on this concept of affordability. And even people who are critics of the ACA, and there have been many critics of the Affordable Care Act, have tended not to say, well, we don't think affordability is a good thing. They've instead complained that the act doesn't actually achieve affordability. So there's an editorial criticizing it as the Unaffordable Care Act. But that, in a way, just emphasizes the fact that affordability is this central theme in the way that, I think especially in the US, we think about the goals of health policy, that affordability ends up being this core theme when thinking about reforms to policies around health insurance, around healthcare services. So for instance, the affordability of hospital services that we've been talking about in some of our other presentations, and access and affordability of prescription drugs. Obviously, again, the second statute references that, and that is another major theme in US health policy. And what I want to focus on for today is the fact that affordability often gets referenced, again, in the titles of these well-known pieces of legislation, in speeches by politicians, but rarely gets defined. So the first quote I have for you up here on the slide this is from a policy brief by the Leonard Davis Institute at UPenn, a very well-known health economics sort of university-based thought leadership org think tank. This is a heading from one of their sections. They say, healthcare affordability often invoked, so often put in the text of a bill, often sort of named as an important objective by a politician, but not often defined. And what I like about the way they put it is that then they say something that I find really interesting, which is they say, unlike most other economic measures, things like, supply, demand, various kinds of trade-offs that can be quantified more easily or measured, they say affordability is essentially a sentiment. One way I might gloss this at the risk of just being anachronistic going up here saying this is, affordability is a kind of, it's vibes in a way that other economic measures aren't. It's something that is a sentiment and has to do with the way that people react. And the second set of quotes down here I have is from Jonathan Gruber. I don't know if anyone here is familiar with Jonathan Gruber, but he was the health economist at MIT who was generally considered to be a maybe more conservative health economist, who was actually an architect ultimately of the Obamacare, the ACA, after being very heavily involved in the Massachusetts health plan, Romneycare, that was a predecessor to the ACA. And what Professor Gruber says, and this is a quote from a lecture that he gave, I don't know if any of our speakers or folks here who are health economists have seen this. This is a lecture he gave for the Health Economics National Conference, talking about how he approached affordability when he was asked about it by the Massachusetts legislators. And he said, my first reaction is to avoid talking about affordability. It's not even a real economic concept. But he decided that if he was going to contribute to this conversation, he needed to have something to say about what affordability was. So there's this phenomenon where affordability is both recognized as something that, regardless of how it's defined, it seems like the public and policymakers care about it, but economists and health policy experts are often, seem sort of hesitant to define it precisely or kind of skeptical of its worth as a concept. And what I want to get into, my goal for this presentation is to try to look at different ways that we might define affordability, connect those potential definitions to different kinds of ethical foundations that we might see as relevant for the US healthcare system, and then think about which of these potential definitions of affordability might be more or less ethically compelling. So, first thing I want to flag is that, so I'm giving this talk in the US, so it's easy, I think, for us to see, having seen the ACA and other legislation, why Americans care about affordability. But to flag that affordability to individuals and individual households of health insurance and health care is mostly, not entirely, but mostly a preoccupation of the US having to do with the way that the US healthcare system is structured differently from systems in other countries. So in the UK, the societal affordability of healthcare is a big issue. The affordability of healthcare provision to the UK's budget, national budget, that's a big issue. And their National Health Service has sub-agencies within it whose task is to try to fit the most cost-effective health services into that budget. So the same topics that Professor Alexander was talking about finding the most beneficial uses for your limited healthcare dollars. But the flip side there is, even though they're much more sort of concerned about this, individual affordability of insurance or of healthcare services is not in any way as substantial an issue in the UK as in the US, outside of a few special categories like, say, dental care services that don't fall within the National Health Service's public provision. The UK moves the affordability conversation from is it affordable for me or for you to is it affordable for us as UK society. In some other countries like Canada and New Zealand, there can be challenges having to do with individual affordability of prescription drugs, pharmaceuticals, because individuals are asked to pay some cost sharing for those products. But affordability of healthcare and insurance still isn't the same sort of challenge as it is here. So this just underscores the way in which the affordability issue focused at the household level is really a preoccupation that is mostly or particularly an American one. So I want to put up here, and we'll see how it plays out. Get out your phone if you feel willing to go along. I want to just think for a second about different ways that we might all define the concept of affordability. So what I want to do is, I have a polling software, and we'll see if it works, where you can respond and just, it should put up a word cloud, and I'll refresh the window of how we would, different ways that we might define affordability. So I'll just actually pause and just leave it up here for a minute to see if what ways of defining affordability folks have in mind. Right, so I'm seeing some things coming in, showing up in the word cloud, so thank you all for responding. So yeah, so ideas like affordability has to do with attainability, so maybe has to do with access. Seeing other things like, something is affordable if the cost maybe is low in absolute terms. Something is affordable if it's inexpensive or cheap. Another element which we've seen talked about in Professor Alexander's presentation is maybe there's some connection between affordability and equity. Perhaps it's that for something to count as affordable, it has to be equitable in some way, or alternatively, maybe it's that something being affordable is a way of serving the goal of equity. Everyone, I think, seeing the word cloud doesn't want to pick the same. If you pick the same one, like attainable, it just makes it bigger. So feel free to pick the same word as other folks have picked. But this really, I think, seeing this going up here sets the stage for some of the definitions that we'll talk about. So some of the definitions around things like being inexpensive or cheap in absolute terms. Proportional, I'll actually get back to this at the end of my talk when you ask questions, and I'll ask you a question first, which I'll be interested in what it means for it to be proportional. Proportional to what? So maybe something like the costs are proportional to the medical benefits. But I think access and attainability are really useful definitions, but also get to this issue of, that just sort of pushes the conversation back one step, which is, you might say, attainable and accessible, but it's really like, look, anything can be attainable and accessible at, a very high cost. Like, I could stay for a month at like the, fanciest Ritz-Carlton in San Francisco. It's formally accessible, but it would cost a lot of money. So it would not be accessible wouldn't be inexpensive or cheap. It might not be proportional to the benefit that I would get from it. And so some of these are going to be the concepts that will go on further. So thank you for indulging me on this. And I think this has been helpful at getting some sense of the responses you're giving really track with the way that policymakers also talk about these things. So in health law, how affordability has tended to be defined is first in the ACA. We talked a little bit about this, 8.5% of income, you shouldn't have to pay more than that. Beyond that, you get federal subsidies to keep the insurance costs below 8.5% of your household income. And this seems to be how the Affordable Care Act defines affordability standards for health insurance. They use the specified percentage, and the way that the Inflation Reduction Act has amended the ACA's approach is to say, no matter how high your income is, if insurance were to cost more than 8.5% of that income, then it would count as unaffordable. And you might reflect, based on how you answered the word cloud, whether you think that 8.5% cutoff matches how you would understand affordability. That would mean that, for instance, a household that was very, very wealthy might still have insurance count as unaffordable, even if they still had tons of disposable income left over after paying for insurance, more disposable income than maybe another household had as their total income, even before paying for insurance. Many state statutes reference affordability as an aim of health programs. So reference that they say the goal of, or health insurance regulations, the affordability standards that Professor Goodixon talked about earlier is, goal of having insurance affordability being important, prescription drug affordability boards have been recently set up in many different US states to try to rein in unaffordable costs for prescription drugs. And then also there are concerns about unaffordability of healthcare services. And the issues of affordability are not unique to health, even though health is a unique good. So there are many other essentials that affordability standards or definitions are also generated for. So for housing in the US, affordability is defined in different ways in different regulations and statutes at the local level, the state level, nationally. A common definition of affordability for housing is that housing is affordable if it consumes no more than either about 30% or sometimes up to a third of a household's income. So again, you have that percentage of income definition that often gets used for housing. There are other definitions that get used for what it is for electricity or other essential utilities to be affordable, water to be affordable. Some jurisdictions define that in terms of the median income. So what percentage of the area's median income somebody would need to pay for water or electrical services. Other sort of important goods, childcare. So childcare affordability, measuring that is something that policymakers have been interested in. And then last, and something that may be sort of closest to home for many of you, is this question of how affordability gets defined for another good that is not maybe as essential to life and limb as healthcare services or electricity and water, but bias as a professor and hopefully you all as students think is important, which is higher education in the US. That's another good where again we think about what does it mean for higher education to be affordable versus unaffordable? Is it just about how much you pay? Is it about the return on investment, improving skills, career opportunities? I'm going to contrast all of these with a different good or service, you might call it, in the US that we don't typically think of through this lens of affordability, which is primary and secondary education. So unlike housing, unlike electricity or daycare or college, we typically, in the US, every state provides public elementary and secondary education in a way that's fully publicly financed. So the approach in the US to primary and secondary education is more like the way the UK approaches healthcare and the NHS, that it is a publicly financed rather than privately financed service, even though it's regarded as an essential in the same way that housing or water or electricity are. So it's not only regarded as an essential, but it's fully publicly financed. Whereas in contrast, housing, food, electricity, and water, there are programs to assist lower income households in obtaining those essentials, but they're not fully publicly financed for most people in the way that primary, secondary education are. So that's something to flag and come back to think about when we talk about what the role of affordability should be is, should healthcare and health insurance look more like daycare or college or housing, where they are privately purchased, although they are financed through things like public subsidies or limits on how much a household can be asked to pay? Or should they be in this more primary education type model? And in the US, I think we sometimes toggle back and forth between what we think is the right way of framing healthcare and health insurance. The couple questions that come up for affordability at this point, I think, are first, should our affordability standards be the same for all these different dimensions of health spending? So is what it means for health insurance to be affordable the same as what it should mean for pharmaceuticals to be affordable or a given healthcare service to be affordable? Again, in our first presentation, we learned about how you might pay $102,000 at the high end for a joint replacement, and even at the low end, you might pay $32,000, which is a big portion, if you were to pay that out of pocket, of most U.S. households, the sort of median U.S. household income. At the same time, the fact that a joint replacement is a health procedure that is durable, you don't have to keep getting that replacement every year, does that affect what it means for that to be affordable compared to something like insulin? And then the second thing which I want to get into next is what is the ethical foundation for potential definitions of affordability that we might look at? So when we want to define affordability in one way as opposed to another, one way of trying to pick among definitions is to think about, which definition fits best with, or best helps us get to the sort of U.S. health system or structure of U.S. society that we want, that we think is best. And the question about that best structure is going to depend on or differing views about distributive justice, about ethical foundations. So I'm going to turn to that next before we then look at what some of the different definitions of affordability actually are. So one potential ethical foundation, and again, I'm grateful to go last because we've sort of talked about this already. One is this idea of kind of maximizing benefits, maximizing societal maybe well-being or efficiency. And to do that, you would say, we should define affordability in a way that creates policies that end up realizing the greatest overall societal benefits. We want to define affordability in a way that leads to overall societal benefits being maximized. And the way that the definition might make a difference is if your affordability definition is connected to how governmental subsidies are assigned or who's eligible for them, then depending on how you define affordability, it'll affect how resources are spent or distributed, which will in turn affect sort of overall social well-being, overall benefits. Another ethical foundation that sometimes can align with or compete with maximizing benefits is what sort of political philosophers, legal theorists, others might call egalitarianism. And coming back to the primary school example, this is also something that plays a role in the way we think in other countries and even the US about many of these essentials. And the thought here might be that we should define affordability in a way that enables equal access or equal attainability for all households, that makes health services or healthcare, health insurance equally attainable for everyone. That attainability of health services or healthcare, unlike luxury goods, shouldn't depend on household income, should be disconnected. And in some ways, that's the way that I think we often think about elementary school. Whether you can go to elementary school should be separate from the issue of what your household income is. Another philosophical view which can align with egalitarianism but is different in important ways is this idea of prioritarianism, or giving a special priority to the worst off or the least advantaged in society. And what this approach might say about affordability is that we should select a definition of affordability that maximizes access to healthcare services, health insurance, prescription drugs, and so on for the worst off individuals or households in society. So, and that might be true even if the access is not absolutely equal across everybody. The concern is maximizing the position of the poorest or multidimensionally least advantaged households or individuals. So households that are living in communities that are subject to structural racism, households that are living in areas that are poorly served by infrastructure, going even beyond things like just income, might also fit into this notion of prioritarianism. A sort of cousin of prioritarianism that's a little bit less demanding ethically is sometimes called by philosophers, only philosophers come up with this sort of word, sufficientarianism. Which is that it's not that you have to maximize the position of the least advantaged or give a special weight to the least advantaged. So prioritarianism doesn't necessarily need to be about maximizing the position of the least advantaged, but it could be about giving a special importance to access for them. Sufficientarianism is a little bit more modest. It just says you need to get everybody sort of up to a decent minimum. Professor Alexander talked about that a little bit in her presentation as well. So sufficientarianism says we define affordability in a way that ensures that everybody has a decent minimum of access to health insurance and health services. Then last is a foundation that I find personally very interesting. It's what I wrote my dissertation about, but doesn't get talked about as much in philosophical theory, which is that sometimes we define a societal goal as avoiding economic disruption or maintaining economic status. That we don't want households to experience downward economic mobility or drop down in the economic ladder because of health spending or being uninsured. And so another goal we might have for affordability definitions is to say that we want to define affordability in a way that makes certain that no household experiences a disruption to their accustomed lifestyle or drops down economically because of having to pay for health insurance or having to pay for healthcare services as the result of services being very expensive or being uninsured or underinsured. So now I'll go through some of the different definitions that health policymakers and policy scholars have looked at for affordability. And some of them really mirror, a lot of them mirror what you gave to me as part of that word cloud. So one, which you all didn't give, it was kind of what I was asking you, is to define affordability in a way that I would call descriptive, to say, well, to know what affordability means, what you just got to do is got to take a poll, and then affordability is just whatever individuals think it is. And that can be a helpful way of defining affordability, but it can't be sufficient on its own. Because when you were each responding to the word cloud, I don't think you were thinking, well, I got to figure out what everybody else thinks it is, and then I'll write that. When I'm defining affordability, I'm not trying to think, what does, Rick, what does Professor Alexander, what do they think it is? In general, we're trying for ourselves to define affordability, and then aggregating what we think together might be a way of defining it. But the descriptive definition has to depend on some underlying theory that each of you has of what affordability means. When you were writing down what it meant, you were basing it on some idea that you had that came from somewhere else besides the sum of what me and you and everybody else think about what it is. So it can be helpful as a way of polling, but it's not enough. Another way of defining it, which connects to something that Professor, when I was asking the question in the first panel about how the states defined affordability, is you could define it, and this is convenient because it's easy to measure, is as some function of what individuals or households happen to be paying right now. So the state insurance affordability boards that have defined affordability as, say, an increase of no more than 2% or 3% over consumer price inflation. That's an easily operationalized definition, is just to say, well, it's whatever people are currently paying plus something, it's some function of that. Challenge is that this, I think, can be helpful, but won't necessarily guide comprehensive reform. So if we have good reason to think that there's something unjust about what a lot of households are paying, then just saying, well, it's unaffordable if it's more than 2% more than they were paying last year is not necessarily going to address the comprehensive concern about households' insurance or healthcare services being unattainable or inaccessible or not good value for money for some households. Another set of definitions are these sort of definitions in terms of, coming back to what I said about sufficientarianism, a decent minimum. So you might either say it's defined in terms of access for households that are poorer. A challenge for defining affordability as something like, well, something's affordable if it's accessible to households in the lower part of the economic stratum, X percentage of poverty. If they can access insurance, then we've achieved affordability. The challenge there is this doesn't address the problem that what if middle-class households drop down a lot economically or even become impoverished as the result of paying for healthcare or health insurance? It also doesn't address other economic challenges. And if we think those are relevant, then we think that access to poor households might be a piece of the picture for defining affordability, but doesn't exhaust everything that we care about. A different definition, which you could combine with the first one, is you could say, well, just add on access for poor households plus access that doesn't impoverish households that aren't poor already. The first sort of, this is maybe a bit pedantic, is if you just had that one, that wouldn't help households that are already poor. This comes up in global health when you're looking at definitions of financial risk protection. If a household doesn't cross the poverty threshold, but is already poor and gets poorer, that seems like it should matter. That seems like a bad outcome for that household, that a metric of affordability should capture. And the other, coming back to the first one, is that even combining access for the poor plus non-impoverishment doesn't address some economic burdens that households might face that fall short of impoverishment. So the decent minimum definitions, I think, are in some ways more promising than just saying, well, it's whatever people think it is, or it's whatever they were paying before. So I think that they're a piece of the puzzle, but they are often not going to be sufficient on their own. Another category of potential ways of defining affordability for healthcare and health insurance, I would class as definitions in terms of a household's or individual's plan of life. So one way of defining affordability is, well, these health spending outlays are affordable if you can pay for healthcare, health insurance without experiencing any disruption to your current life plan. If there's nothing, if it doesn't affect your current life plan at all. And this expectation, and in some ways, again, this is kind of how we think about the fact that you don't have to pay to go to elementary school. But we might think that, unlike primary education, it's an unreasonable expectation to think that there should be no disruption to your current life plan. So it's not how we think about housing, not how we think about childcare, not how we think about higher education. We think that even though these are important goods or even essentials, that it's acceptable to ask households to engage in some trade-offs or to accept some disruption to their life plans to pay for these essentials. And the question is going to be, if you think that some disruption is okay, sort of how much? So one account that's been proposed by a health policy scholar who I've actually worked with on other projects, Professor Carla Cyans at the Pan American Health Organization, is she tries to define it in terms of what she calls a reasonable trade-off account, where she thinks that health insurance is affordable if, in paying for it, you don't have to give up access to anything that's comparably as important as health insurance. And there's something somewhat compelling about that. But a challenge for this, I think, is that opportunity costs in economics are going to be inescapable. So a rational individual or household is going to sort of, it's like Maslow's hierarchy of needs, is going to arrange spending to meet their sort of most critical needs first, next most after that, sort of going down the ladder. And the next thing that you would pay for, if you didn't have to pay as much for healthcare or health insurance, would be the thing you regard as the next most important. So almost as important as the way that you regard health insurance. So I think the reasonable trade-off account gets at something, which is that we want maybe that there's some disruption that's okay, but not unreasonable disruption. But the way that this, there's more details of this that we could talk about in the Q&A if folks want, demands too much in saying that we shouldn't have to bear burdens as the result of the opportunity cost of having to pay for health insurance. A different way of defining it is to say that the access or attainability of insurance has to be compatible with a reasonable range of life plans, so that it has to be that you can get health insurance or health care while also being able to pursue a reasonable range of life plans. So it shouldn't be the case that the only way that you can get insurance is that you're confined to a narrow set of jobs, or that you can only get health care in this one state that covers these procedures, and so you can't move to a different state. So this is a different way that says there can be some disruption. There are some ways in which, just as, for instance, if you're paying for college or for housing, you might have to accept trade-offs in the other, so live in less generous or convenient housing if you're paying a lot for college, or vice versa, sort of delay higher education if you're spending a lot on housing. There might be trade-offs you have to make, but as long as they're compatible with a reasonable range of options and life plans, say in where you live or where you go to school, that can be okay. So that's another way that you could define affordability as access compatible with a reasonable range of life plans. Last category, and this gets to the folks who put cheap or inexpensive, is some folks would define affordability as either something being low in absolute cost. It's just very cheap. It costs less than some fixed amount. You sort of see this in some statutes. One challenge is this is a little bit oversimplified, because what if something is a very good buy in terms of benefits, but has a high absolute cost? So the way this comes up at a societal level is when there were these new hepatitis C treatments, they were a super expensive one-shot, essentially, not one-shot, it was a pill series. They cured hep C. You didn't have to deal with the chronic illness long-term costs. But the absolute costs of these drugs were high, even though their cost effectiveness was good because they had the benefit, again, going back to Professor Alexander's talk, spirals out over all the years the person would otherwise have been dealing with chronic hep C, dealing with liver failure, potentially liver transplants, things like that. So low absolute cost, I think, can't be enough. Value for money, I think one question is, value for money, certainly the societal level is what's important. I don't think it can be all of what we care about at the individual level, because something could be good value for money. It could be very cost effective because you're in a very bad position. Say you're 18 and you are diagnosed with a cancer where you would, if you don't get treatment, you'll die in the next year. If you get it and you can cure the cancer, the person is going to live for another, 60, 70 years. Very good value for money, but does that mean that we should ask the household to pay, if you're an economist, you're calculating the cost per life year, it's an enormous number of dollars that is the value for money of that cancer treatment. But is it reasonable to ask, even if it's reasonable to ask, say, the UK government to pay that, or the US government, is it reasonable to ask that of an individual household? And I think often not. So value for money is a piece of the puzzle, but there might be cases where something is really good value for money, but it's still just not affordable because there's more to affordability than it being good value for money. It's too disruptive to that 18-year-old to be asked to sacrifice, going to college for some long period of time because they're having to pay for a very expensive chemotherapy. So here are some different ways that we might try to bring together or connect these definitions that I've offered. So one that you see a lot, and it's not surprising because of the way that sort of politics tends to work, although as a philosopher, philosophers are obsessed with definitions and defining terms. You all are nodding. You've probably had papers back from or illustrious organizers saying, define what this means, define your terms in before you set out your thesis. You can just avoid defining affordability, as you often see in these pieces of legislation. There's a famous quote from Jacques Maritain, who is a priest, actually, who's involved in drafting the Universal Declaration of Human Rights. And what Maritain said is that you can get people to agree on human rights as long as you don't ask them why they agree on human rights, what the foundation is. And so by avoiding a definition, you can get more wide agreement maybe on a piece of legislation or on affordability as kind of an aim of health policy. The problem is that if you have this lack of definition, you get the problem of people talking past each other, that they're talking about affordability, but they're not defining it the same way, and so you get these very confusing disagreements about whether a policy actually achieves affordability. So as a philosopher as well as a lawyer, I find myself allergic to the idea of just avoiding defining affordability at all. Another approach you might have is kind of going along the lines of what I said about primary education. You might say, just caring about affordability is getting things all wrong. Affordability shouldn't be the appropriate goal because it's putting something in the market. It's accepting it as something you should have to pay for or not. Something that should be outside the realm of household spending. Affordability shouldn't be the goal for health insurance. Instead, it should be something more universal in terms of access than the ways that I've talked about affordability. It should be that there's kind of universal access at zero cost for all households. there are challenges there in terms of both how practicable this is realistically in a country like the US, and then the flip side, there's reasonable disagreement about this, and the other is that there are other essentials, things like housing, things like electricity or childcare, that are really important essentials, but we don't think need to be provided by complete first dollar public financing. Another thing you might do is you say, get rid of affordability as this umbrella concept, and instead just talk about these constituent values, value for money, not disrupting people's life plans. Maybe something about percentage of income or public values. You see this for other ideas as well. So some people, for instance, for terms like BIPOC say, instead of using this term, which is confusing, just name the groups that you care about. There's a famous law professor who was emeritus when I was in law school who said, instead of talking about property as a concept, he had this famous article called The Disintegration of Property, where instead we should just talk about the discrete parts of property rights. The right to exclude, the right to transfer, the right to bequeath, instead of talking about property as a unified concept. This has a lot of appeal, but at the same time, the fact that people care so much about affordability is kind of a reason to keep it around. It can make the conversation simpler if we can have a definition, and it can integrate some of these different concepts or values that we care about. And then last, you might try to come up with one sort of univocal definition of affordability. We might either pick one definition of those that I've talked about before, or we might try to combine them. So what I want to suggest on this last slide is that I think the best way forward in terms of defining affordability is to try to combine some of these different definitions that I've talked about so far. So I think, my way that I would do it is to say the most compelling way of defining this concept of affordability in health is to combine something like access for households that are poorer, access for everybody else, regardless of poor or not, that's compatible with a reasonable range of life plans. And then some notion of value for money mattering as well. So that's what I'm going to leave you with as my suggestion for how we might define affordability in health. Even if I haven't convinced you of this definition, I hope to at least have made the case for why having some definition of affordability could be an important and valuable thing. So thanks, and I'm looking forward to the questions.
We'll now hear from our formal respondents. After each, Professor Persad will have a chance to reply. After that, we'll open the floor to you all for your questions and comments. Hannah?
Sorry about that. Thank you for the talk. That was very informative, and I'm thankful that you gave us many themes or topics to think about regarding affordability. If I may ask, you discussed sufficientarianism in your talk, to having like a bar, not bare minimum, but having like a bar or minimum where people should reach on a general scale. Where would you draw the line when deciding how much health care a family or individual receives, like pediatrics, orthodontics?
Yeah, so this is a great question. I think there's sort of two different kinds of decent minimums we might think about. One is what should be in the package of healthcare services that are covered by health insurance that's affordable. And then the other is what is the decent minimum economic level that you should be left at after you pay for healthcare services or health insurance. And in my talk, I was sort of thinking more about the second thing, which is that households shouldn't be left below a decent economic minimum after they pay for however much healthcare or health insurance they end up needing to use or purchase. But the question of sufficientarianism about the healthcare package is also an important one, although not one that I really tried to answer in this project. I think it ends up being challenging because in the UK system, you have a national standard for what that package looks like, what the package of services that you get in the NHS is. One question maybe for me to think about is going to be, when I say something like, well, health insurance should be affordable. What does it mean? What package should health insurance have to contain to count as health insurance that is affordable? And this is a question that the ACA's drafters wrestled with, and they defined 10 very broad categories of essential health benefits. And then within those categories did things like saying, well, you've got to cover 2 drugs in each therapeutic class, plus in some more privileged classes, maybe you have to cover more drugs. And I think we've been really hesitant to have that national conversation about what the decent minimum content should be for plans. And I tend to think there are some good reasons for that, in that I'm not sure it would be nice if, given reasonable disagreement about what is important to people, if we didn't have to have everybody agree together on what healthcare services counted as the ones that insurance should cover. Because people reasonably disagree, I think, about what a good life looks like. But is there some way, even if there's variation in content, of like setting and defining a baseline of what is it for something to count as health insurance, a sort of quality minimum, I think is an important question.
Thank you. That was a very clear response. And if I may ask one more question, you discussed in your talk how for when trying to define affordability, having a definition. Actually, let me rephrase that. Avoiding having a definition can allow for more answers by not like narrowing it down. But at the same time, it also makes the discussion susceptible to disorganization because there's so many possible answers. Is there like a middle ground where we can maybe categorize those answers into not sections, but groups that can maybe simplify the definition a bit?
Yeah, so that's, in a way, that's sort of what I was trying to do by, so what you might say is like a kind of taxonomy of definitions of affordability. That's sort of what I was trying to do there by trying to create these families of like life plan-based, descriptive, decent minimum-based, and value-based definitions. Then in a way, like for each of these, right, the definition of affordability is going to be in terms of some other concept that might itself be disputed or not precisely defined. So when I say something like a reasonable range of life plans, this just pushes back the question to, what is a reasonable range? Or if I'm defining life plans in terms of households not being impoverished, or the poorest households having access. You might then ask, what does it mean to be the poorest households? Does it mean less than 400% of the poverty line? Or what does it mean to be impoverished? Countries in Europe define poverty differently from the way that we define poverty in the US. So yeah, I think there can be value in having, even if not a sort of precise definition that everybody accepts, understanding the differences between different categories of definitions. But yeah, I think you're absolutely right. There could still then be disagreements sort of within the category of, even if both, say, groups agree that we're defining affordability partially in terms of some decent minimum, about what exactly we mean by the decent minimum.
Thank you very much.
Sure.
Terrific, thank you. So first of all, you have to show me the whole word cloud thing. That was really cool. But that's not a question.
We can go back to the word cloud. Yeah.
I enjoyed your presentation. I wondered if you could expand a little bit more on the work you see being done with a better definition of affordability. Like, how do you see this practically changing our healthcare debate? So that's my first question. And my second is how, if at all, you see affordability connecting with moral hazard. Because one of the things I personally struggle with is I think the empirical evidence of moral hazard is compelling. And I want universal access to care at some baseline, and I'm an honest enough person to admit that those pull in opposite directions, so I'm hoping you'll solve it for me.
So, yeah, so I mean, part of it is I'd be really interested in some ways of getting more of a sense of the experiences of folks like you and Professor Giddix and others who've sort of seen these things playing out at the actual policy level. Like, my sense is that legislators and chiefs of staff are not naive people, and they often, I would suspect, kind of get that they're being vague about how some terms are defined, or that there's disagreement. And I'm curious about whether they would see value, or whether sort of tacitly, even if they're not putting it into the text of the statute as, well, affordability is defined to mean this, whether they sort of have a tacit understanding of what they think it means when they're drafting legislation. I guess to me, I think, and this is I think maybe too an approach that you would think of as too much of a philosopher's approach and too little of a policymaker's approach, is that then we could at least have like a clearer conversation if we defined our terms about whether a given policy reform was actually achieving affordability if all the interlocutors had some degree of common agreement on what the term is that was defined. Because you could get, for instance, both, people, when you talk about the Inflation Reduction Act, people advocating for all sorts of different versions of it, or Build Back Better, could all kind of claim the mantle of affordability if it's defined very non-specifically. But if you had a more specific definition, there are two things that you might be able to do. One is that then you might be able to say, look, we can hire an empirical expert like Professor Goodixon to look at this and see, hey, actually this doesn't achieve the definition that we agreed to. Or alternatively, you could look at an empirical measure and say, well, this measure is easy to operationalize. What John Gruber did when he was drafting some of the ACA stuff is he said something like, well, we'll look at how much like households spend on food and housing and something else, and we'll just stipulate that some transformation of that, their spending on that, I need to state it more precisely, he just sort of stipulated a definition in terms of things that were easy to measure for him. This is something that people often do in empirical research because it's good to have metrics that are based on information that's easy to access. But the problem there is that you can kind of end up with what people call the streetlight effect fallacy, that where, well, it's easy to measure, so we're going to regard this as important. But if we had a definition of affordability, we might then be able to say, okay, sure, this is, 85% of income or whatever, it's easy to measure, but it's not getting at all of or most of, it's missing some of the things that ethically we care about when we decided that affordability mattered in the first place. So sure, this policy is good at achieving this outcome, but it's not clear that this outcome that's operationalizable is capturing what we actually care about. Now for that second thing though, thinking about it, it's not as clear whether for that you need to have as precise a definition of affordability as opposed to just knowing what values matter. So for the second thing, the goal of being able to sort of correct the tendency of policymakers, or at least maybe some people in policies, to want to say, well, we can reduce this down to some numerical threshold and then decide whether that does the work or not. Being able to critique that, you might not need as precise a definition as I've argued for here. Your other question is really good about, can you achieve affordability for households, not have the, my hypothetical about the 18-year-old being asked to pay some huge amount of money for chemo, without running into the problem of moral hazard, where because insurance is covering it, you don't have the same price sensitivity, and so they are ripe marks for getting, overcharged by the company making the chemotherapeutics or something. And a couple different approaches to that I've found really interesting are, one thing that I was thinking about as I was listening to Professor Bailey's talk is whether there might be different extents to which we're comfortable with cost exposure for different types of health spending. So I've talked about health in some ways as being like a big monolithic thing. But really, when I talk about healthcare, there are all kinds of different things that are healthcare. Allergy medication, going to the emergency room, behavioral health, psychiatric treatment, and maybe the extent to which we're comfortable with cost exposure for a household might actually differ across different interventions, where there might be some where we're less comfortable with cost exposure as a way of reducing moral hazard, and others where we're more comfortable. The other thing that comes to mind is something that some colleagues of mine had proposed in a piece in JAMA a while ago, and that there's been really interesting research about by some teams that have done deliberative exercises with actually Medi-Cal beneficiaries, which is that one way of the sort of traditional economic way of addressing moral hazard is to give skin in the game to the patients, which means that they're stuck with out-of-pocket if they, as the sort of price of getting health care in order to make sure that they shop around. But the other thing that you can do is, instead of making them pay out of pocket if their health care is expensive, you can kind of restructure it so that they get money back if they pick a cheaper option. So you can try to address the moral hazard by what they call in the JAMA piece, like inclusive shared savings. So basically, if I pick the cheaper allergy testing or whatever, if I forego this, then I get some share of the money that the health system saves. And the Medi-Cal thing that I just thought was really cool, and nice being in California to talk about it, is that when they asked Medi-Cal beneficiaries, like with cancer or other conditions, if what they cared about, like what they wanted the most was like, and I think you'll find this interesting for your work, is did they care the most about like unrestricted, like first dollar, no copay access to the widest possible formulary of cancer drugs? Or would they have rather accepted somewhat more limited access, but in exchange receive some of the money the healthcare system is spending on that, on other types of benefits? This is a study that Marion Danis and Susan Gould, who are health policy folks at the NIH and Michigan did. And what they found was that the Medi-Cal beneficiaries actually, many of them would have preferred a smaller formulary if they could have gotten some of the money as, being able to have access to counseling, or being able to have a home health nurse, or being able to actually have, the money just come back to them as cash benefits. And so I think that idea of having sort of addressing moral hazard, instead of you having like skin in the game that you're going to get pinched if you buy something expensive, you have, treats in the game that you get some. I mean, treats is, I shouldn't put it that way, because getting counseling if you have cancer isn't a treat. It's something that's really valuable. But having an incentive that's positive as opposed to the risk of having to pay more, I think is another idea that's potentially promising. There are interesting challenges there with like anti-kickback law and stuff, but that's another area that I think is really worth thinking about if you care about affordability, but you're also worried about moral hazard. Right.
Thank you.
The floor is now open for your questions. As previously mentioned, this event is being recorded by Access Sacramento. To ensure that your questions or comments make it onto the recording, please use the microphone that is stage left.
I want to speak about affordability. United States based off of two principles: freedom, and which includes equality to all, despite the diverse population you might be part of or not part of. And the other one is immigration. Since the Massachusetts Bay Colony, immigrants came to the United States to better their life for themselves and their family. And this whole country, United States, is about a melting pot of immigrants. So everybody's actually an immigrant in one way or another. If you don't agree or not agree, it's a fact. And so by the immigration laws, it would be a violation of the Constitution, because that's what this country is about. But affordability, and since this country, United States, is about, like I live with ADHD. I wasn't asked to be disabled, but yet I am. I wasn't asked to be on SSI, Social Security, but yet we are. But we should not be penalized for something we have no control over. So by creating laws and regulations that contradicts what the Constitution, the 14th Amendment, suggests you not to do and forbids you not to do, you actually violate what this country is all about. And since this country is about equality, everybody needs to be treated equal. That means paying the same amount in wages, depending, but not all of diversity. Pay the same amount of wages, pay the same amount in health care, pay the same amount of everything. Nobody should be treated different because of the diverse population, because this country is about equality. Equality for all. Immigrants, equality for all United States citizens. and we all should be treated equal because our founding fathers and Martin Luther King and many other people died for those constitutional rights. So all United States are treated equal.
Thank you so much. Yeah, so I think one thing that that comment raises is just sometimes identical treatment of households that are coming from different places may not necessarily be fair or equal in terms of results. So going back to the 8.5% of income test, one thing that's interesting is in the Affordable Care Act, 8.5% is appropriate if you're 400% of poverty or higher. But if you're lower, if you go down to 300, 200%, they actually say it's a smaller percentage of income that it's reasonable to ask you to pay for health care if you're at 200% of poverty compared to 400%. So what I would say is that it can be challenging to understand how to operationalize the idea of equal treatment, because identical treatment of households based on some way of defining identical, say, same percentage of income, may not necessarily achieve results that we think are fair, given the different positions the different households are in. But I thank you for the comment.
So in classic philosopher style, right, there's quite a talk trying to figure out what affordability means, right? Because when you really dig into it, words are hard. And so I hesitate to ask this because it might necessitate an even longer talk, but what is society? I think a lot of your talk, the previous question, all seem to, I think, assume nationalism, that we're thinking on a national basis. I think you could question that in both directions. Right? On the one hand, you talked about prioritarianism, helping those who are worse off. Most people in the world live on a total income every year that's less than just what the average American spends on healthcare alone, $11,000. So should we be finding some way to shift medical resources in their direction? Or if not, in the other direction, should we be thinking on a smaller scale, like the state, which we've talked about somewhat, or smaller scales like the city or the family, just what makes the country the right unit of analysis?
Right, yeah. So I actually don't think, and forgive me if I've misstated it, because I was talking about the US healthcare system, I think you're right to point out that in some ways I implicitly assumed that we would need to have a common definition sort of across the US. In part, I did that because I was trying to contrast the US with other national systems that seem to take a different approach to healthcare. But I think it's right that potentially you could have different ways of, one way of putting it is that you might have the same qualitative definition of affordability across different localities or jurisdictions. The same ethical values might be sort of combined together, what it means to achieve affordability. But because of differences economically and otherwise between jurisdictions, how you operationalize that qualitative definition in terms of numbers might vary quite a bit. So one thing that's interesting that you don't see, I believe, with the ACA, but you could imagine seeing, and you do see in practice because of different states having different local policies, is that you could imagine a system where instead of just looking at income, you looked at some relationship, and for instance, between household income and state median income, where you looked at how, say, the household's residual income after paying for whatever the health services we're thinking about, how their residual income stacks up against sort of the local cost of purchasing some basket of services. You could almost look at it against sort of local, you can incorporate local variation in purchasing power more robustly if you wanted to. So I think that'd be very interesting. One thing that comes to mind for this actually is that I know that California, before the Inflation Reduction Act, had done something I found really fascinating, which is that they had already extended subsidies, I believe, my colleagues will correct me if I'm wrong, had extended subsidies to people above 400% of poverty before the ACA, the Inflation Reduction Act did it nationally. And this could reflect sort of different local politics in California, But it could also reflect the fact that California cost of living is higher, and so households were feeling more pinched, even if they're above 400% of the US poverty line, than they would have felt in a state where cost of living was lower. Now, the international, in a way, I meant to be agnostic about the level at which we're talking about affordability, although the focus of the talk was affordability to individuals or households. So it was actually on a very micro level. But there are all sorts of other levels at which we might also analyze the concept, whether that is affordability at the national level, like we talked about with the NHS approach, affordability at the state level, say within a state budget, or some other subnational entity. I think the idea of what it would mean to think about affordability globally is really interesting. The challenge for global policy making, which we dealt with when I was working with some colleagues on global vaccine allocation, is unlike with the US or California or Sacramento, there's no really global body that's empowered, for instance, to do like revenue raising, to do like some of the global, subsidies or other things that you might do to achieve affordability globally. And so, for instance, to achieve affordability of pharmaceuticals globally, you end up, and you're probably familiar with this very interesting and hard problem, which is that since there's no way of doing it through taxes and subsidies, you are stuck with trying to do it by setting price caps so that somebody in, Malawi can afford a drug that would be very expensive for them. But then you have to make sure that the drug doesn't get imported from Malawi to countries where people have higher ability to pay, because then it would end up being not profitable potentially for the company to invest in producing the drug at the same price. So you get all sorts of interesting challenges at the global level from the fact that we don't have access to achieving affordability through taxes and subsidies or some of the other tools, or the kind of like thing that I was mentioning to Professor Alexander's question of having the, you'll pay the person to take the cheaper drug. You don't have the same robust governance at the international level as you do at the intranational level. And I think there are good reasons for that. Like, I don't think we're at the point as a society of people globally that I would feel wild about like a world government. But the lack of having that authority makes it harder to figure out. I'm actually sort of curious to ask you, if you're willing, like, are there mechanisms that you can think of that would be like effective at realizing some of the affordability things we've talked about, as I was talking about, like at a global scale, or like in.
Do you mind answering that on a mic?
I think it's a good reason for individual people in rich countries to donate abroad, but I think you're right that, for good reason, we don't have a world government that can do transfers like that, and it may not be appropriate for national governments to, at least at a huge scale, export a ton of resources outside of their country, to people they're not elected to represent.
I'm a philosopher. I love definitions. I have two questions about yours. You can imagine an unkind person saying something like, what you've done is you've taken all of this ambiguity about what affordable means, and you just shifted it to a question about what reasonable means, or what life plans count as reasonable. So that's one question. The other one was about your specific proposal, your hybrid definition. Obtainable for the poorest, compatible with reasonable life plans for the middle class. And I was wondering about the way it sounds, there's a kind of differential treatment between these two groups. The poorest, we want health insurance to be obtainable. We want health care to be obtainable. What about their life plans? What about their prospects for their life plans? No. But for the middle class, we definitely want to make sure that they are left with enough so that they have this reasonable life plan, this wide array of whatever. So I was wondering, maybe this is a question for, like, just about the oddness of status maintenance as a principle of distributive justice, at least to my ears.
Great. No, so I'll take them in reverse order because I think they're both really interesting questions. The first one, I think, is, as you probably know in asking it, is this I'll get to it later, but this is a problem for like almost every work of conceptual analysis in philosophy, and that the end, you're just defining concepts in terms of other concepts, and so you know, it's my problem, but it's everybody's problem if they want to do philosophy. But for the second one, I think. Yes, I agree that this is, in some ways, this is a challenge of having sort of domain-specific programs or ways of assisting people that are disadvantaged. So like health-specific as opposed to like paying people a basic income or transferring them all-purpose resources. So like the goal for a household that's in poverty is that they not be, you know, by dint of having to pay for health insurance or, you know, go to the doctor or get insulin or chemo or what have you, that they not be sort of plunged further into disadvantage. But you rightly ask, you know, so the thought is that you don't sort of shift their baseline in a way that is bad for them. But the thing to sort of wonder about is you might say, you know, it's even if we achieve this, you know, even if whatever, you know, say something like Medicaid is comprehensive and so means they don't have to pay out of pocket, that still doesn't affirmatively add to their sort of pile of all-purpose economic resources. And so I think this just is going to raise the question of like, which things should be the task of the sort of health insurance or health care part of, or sort of overall, like spending apparatus? And I guess my answer would be that maybe we do want households that are poor right now, to have access to a broad range of reasonable life plans, but that it would seem maybe just not the thing that the health insurance system is well suited to like positively transfer income or other all-purpose goods to them in addition to access to health care. Now there might be at the same time like sort of in a sense of being not really a philosopher's question, but almost like a social scientist's question. You could imagine, and actually you've seen this in some state health programs, like state Medicaid programs that incorporate things beyond access to health care. So incorporate things like housing, incorporate things like certain forms of education. I don't know if they've gone so far as to incorporate like cash transfers as part of medical insurance. But I mean, one thing that has struck me as really interesting in some ways about the US's approach to healthcare is that you have inside of a society that I think is quite market-oriented in terms of access to other goods, this kind of little island of healthcare where people often are more friendly to the idea of there being non-market approaches. And then one question is then, how big can the healthcare sector get as a way of harnessing or willingness to be more redistributive or be less market-oriented in that sector? And tell me if this makes sense. The worry I have, though, is that if we're willing to say, and I think this is a common thing in the U.S., is that we're willing to say, like, we're worried about, you know, just giving income to poor households because we're like, well, we want to reward hard work, we don't want to, you know, promote irresponsibility or what have you. But we think it would be okay for health care not to be allocated on the basis of hard work or something, but on the basis of need. And then the challenge is that then, since we know that so many other social determinants affect health, we end up then wanting, for political or other reasons, to run all of this other health-promoting redistribution through health systems. So this is an interesting challenge of like, now hospitals want to be like your one-stop center for all these like social determinants. And there's scholarship by other scholars on this that I think is really interesting. And, you know, that's probably better than poor households just like not having access to, you know, education or housing. But hospitals are like, there's no reason to think hospitals are like especially well suited to be your one-stop community shop for all your social determinants, even though hospitals also have reasons to like this because then they get to take some off the top for like indirect costs.
Because, I mean, I guess what I was thinking as a kind of a diehard sufficientarian type, the proposal just seemed like a weird form of prioritizing the interests of the middle class relative to the poorest. I mean, just to use a different example, people lose their jobs all the time through no fault of their own. We're not going to, as a matter of distributive justice, not let them like fall below some kind of decent minimum, but their reasonable life plans are definitely going to take a hit, and maybe that's okay.
Yes, but this is a question that really, like, I still really am interested in it, but, you know, you have to specialize in things. And because here's the thing that I find just really fascinating about this challenge of the middle class versus the very poorest is if you were, you know, working in a well-paying job and then you became unemployed, you get paid back as a percentage of the income you were making before, even if that's more than the sort of poorest folks were making. Whereas if you were always poor and then you got laid off because of COVID or something, you get, it's related to what you were making before. But our theory normally of like why you get paid is that you get paid based on, I mean, who knows, but it's something like to incentivize you to engage in economically productive activities or something. And if instead you're paying people to, not for that reason, which since they're not working, it seems like it can't be for that, then the puzzle is, why should the fact that I before was, you know, a professor mean that I should get paid more when we're both laid off than somebody who was not making very much money? And kind of like going back to some of the things we talked about before, maybe the answer in part has to do with politics, which is that, you know, being offered like so there's this old fight in, back in like when they were first creating Social Security about whether it was going to be a flat benefit that everybody got the same benefit or whether it was going to be relative to your prior earnings. And there was like this is a big controversy at the time, but one reason why the flat benefit I think might have been less politically popular is that it would be like of sort of less use, it would get people who were higher earners maybe less invested in the system if all they were going to get was a flat benefit. And maybe the sort of security of knowing that you were going to be kept in some proportion to what you're accustomed to was thought to be like politically necessary to get households sort of on board. You could ask something about the 8.5% of income thing, right? You know, why do households that are making, you know, 150K or something, why do we need to protect some of their disposable income? So the other might have to do with politics, but the other might have to do with like, you know, it actually would be really disruptive if like, you know, people have a lot of fixed costs that they incur because they think they're going to be making a certain amount of money. And so if you have to like, even if there are a ton of reasonable plans of life where you would have to like move your houses, move schools, move your kids, things like that, then maybe there does get to be something a little bit more to the idea that we should maintain status at societal cost or societal expense. But I agree that there's this hard dichotomy between things. But yeah, and to your first question that you'd asked, I don't know that I have a perfect answer. I agree that when you define what I'm trying to do, it's sort of what you all have up here, end up defining it in terms of these other things that I could ask all of you, you know, what do you mean by attainable or proportional? So I think in some ways it feels to me like your understanding is richer if you can define the concept in terms of the other concepts, but maybe the richness also comes at the price of there being more.
I'd like to read it because I just scribbled it down. How often does preventable health care enter the conversation of affordable health care? Your poor and impoverished households either can't or will not get care, which catch the onset of costly conditions and treatments. Affordability on the front side may cut costs on the back side for both the patient and the healthcare. In other words, if we as a nation shared the cost for preventative maintenance for all, we, in my humble opinion, would all benefit from low or no cost treatments. So perhaps defining preventative health affordability.
Hey, I really like that suggestion. In some ways, it gets to what I think was a limitation of the way that I talked about individuals and households as the focus here of affordability in this talk, which is that even though we're not the UK, we're not the NHS, there are also societal implications in economic terms, sort of externalities of some people or others being able to access healthcare or choosing to receive certain healthcare interventions that, say, if they're preventative, can reduce long-term healthcare costs. So I think with affordability, yeah, I would want to, I think it would make sense to bring in not only like the importance to the individual or household themselves of being able to access that care, but as you say, another rationale for why you might want to have that access is that there might be valuable social externalities where others would benefit as well. So maybe this suggests that you might be able to differentiate healthcare treatments that count as preventative, where you might almost have like a, this actually gets to something that Professor Alexander's talk covered, which is that the vaccines were covered with like zero cost sharing or something like that, is that right? And one reason why you might have zero cost sharing for certain interventions, as opposed to maybe cost sharing that is modest and compatible with reasonable life plans or yada, yada, whatever I was saying. One reason why you might be even more generous, go to zero cost sharing, or even go to sort of into-pocket payment like you had for some of these COVID vaccine incentive programs, is that there might be some specific categories of healthcare where we think that it's not only that there's a kind of individual entitlement or right to have that care, but where you think that the societal benefits or consequences of them being able to receive that care warrant sort of this extra bit. So I think it comes to this question of, if healthcare isn't, maybe shouldn't be viewed as much of a monolith as I've sometimes presented it here, we might want to have different approaches to some extent for, on the one hand, maybe your allergy treatments, on the other hand, your emergency treatments, and then last, your things like vaccines, where you might want to really, or other preventative care, where you might really want to have them be not just, cheap, but free in order, or even they pay you to get it, in order to really motivate uptake of those interventions that have like big, in the economist jargon, like positive social. I think we're at 4:20, is that right?
We are. Unfortunately, we've reached the end of our session and the end of our symposium. Please join me in thanking not just our presenter and our formal respondents, but also our sponsors who generously made this event possible: the Institute for Humane Studies at George Mason University, the Wagon Liz Foundation with support from Bank of America, the Cosumnes River College Office of the President, and Access Sacramento. Thank you.